can see you.
Perfect.
Okay, great. So thanks so much for you two guys to be here. I think we can get started. We have a lot of participants today, so which is great. So maybe I can do a self-introduction. We can briefly talk about why we want to do this webinar, and then we'll go over some talking points, which could be very interesting to a lot of participants today. So my name is Sylvia. So I'm the co-founder and the CEO of Mira. So probably a lot of people here knows what Mira is doing. So we are a fertility tracker, but the difference is like we track your actual fertility hormone concentrations. So we test your LH hormone, we test your estrogen hormone down to a number. Okay, so then and then this number will be synchronized to the Mira app, and which will do personalized cycle analysis and the cycle prediction for you. So our product has been used by many people who are trying to conceive and trying to avoid pregnancy, and especially with people who have PCOS, who wants to know better about their cycle, who might have a miscarriage or just different conditions. And we all know right now that it's a pretty uncertain time, and a lot of people are unable to go to fertility treatments for something they need help with. And so today, we invite those two really famous doctors from the specifically focus on the natural family planning with us. And we want to provide you this free opportunity. And the goal is really to give everyone some helpful insights and to give some support and maybe even get some your doubts clarified during this tough time. So without further overdue, so maybe I will let those two doctors introduce themselves. I think they can do a better job than me. So Dr. Fehring, do you want to start?
Okay, I can. My name is Richard Fehring, Dr. Richard Fehring. I have a PhD in nursing science. I am currently a professor emeritus at Marquette University. I've been at Marquette for over 40 years now. However, I'm also the director of the Institute for Natural Family Planning. I've been teaching natural family planning since 1985, many thousands of couples. I currently started an institute in 1998, and our institute has a teacher training program for health professionals. So we have physicians, nurses, PAs, CNMs from around the world taking our 3 courses. We also are constantly doing research. We believe that we are an evidence-based system. We developed the system of natural family planning in 1998. I'll talk more about that. And then we also still can teach couples natural family planning, either in person or through online type systems. So that's a little background. I have over 185 articles and studies. A couple, 3 books in regards to human fertility, help edit. So that's some of my expertise.
Sure.
I am happy to be able to maybe partake a few tidbits for your participants today.
Sounds good. Sounds great. Thank you so much, Dr. Fehring. So
Sure.
for everyone who might or may not be familiar with the natural family planning, which is the natural way for you to avoid pregnancy and by watching your hormones. So Dr. Fehring has been one of the pioneers in this industry, invented multiple methods doing this, and obviously published, reviewed many articles. And they're also he's also very much into fertility hormones, into women's health. So we will definitely hear more insights from Dr. Fehring. So maybe Dr. Bouchard, you can introduce yourself too.
Sure. So if you can do a little bit of math, I was 3 years old when Richard was starting to teach natural family planning. And when when I got started with doing some research with Richard, I was a resident, and he's taken me under his wing, and we've done several research papers together. I started research in Parkinson's disease before I got into medical school, and then I shifted over to natural family planning research while I was in medical school. I'm a clinical lecturer at the University of Calgary in Canada, and I deliver babies and I take care of nursing homes. And I have a family practice as well, and I'm going to start some online teaching, and COVID has kind of prompted even more online interactions like this one. So I'm happy to participate, and we'll get started on a clinical trial comparing the Mira monitor to the Clear Blue monitor that's used in the Marquette method in the next month or two. And so I'm optimistic that we'll be able to see the quantitative results from the Mira monitor mirror some of the results we get on the Clear Blue monitor. And hopefully with those quantitative results, we can get more precision in monitoring cycles and help people with analyzing their cycles in more detail from home.
Sounds good. Thanks, Dr. Bouchard. So for everyone, just to give you guys some background, so we're now working, so Mira is now working with the Dr. Bouchard, and which is the, his institute as well, which is University of Calgary, on a trial to evaluate the effectiveness of using Mira for natural family planning. And we're comparing the results and the, patient experience of Mira versus Clear Blue. And in addition to that, there's exciting news because Mira is releasing a new product. So we're launching our estrogen test once in a couple months. So that means the Mira will be not only testing your LH hormone, which means the ovulation, but we'll also test your estrogen at the same time. So this will give you your fertile window, infertile window. This will also give you a lot of insights if you have hormone imbalances. If you're close to perimenopause, you can see the estrogen level will start to shift or start to change. So we are really excited about the new product and also about the collaboration. Great. So, so I think we can jump into some very interesting topics. So we actually got a lot of users questioning about the different hormones, right? So we all know we have different types of hormones, but maybe you guys can give our audience a little bit background about what hormones are in a woman's body, and maybe what hormones they need to pay attention if they're trying to either avoid pregnancy naturally or trying to even get to pregnant.
So I'd be glad to do that. Can I bring up my slides? Would that work?
Sure.
I could go into the share.
Okay, sounds good. So maybe I can stop here and you want to share your screen.
I hope this works. Okay.
Should be.
All right. Okay, now I got to get it into.
Yeah, I can see your screen.
Okay. Slideshow. There we go. Okay. Yeah, I thought it'd be a good idea to give a little bit of short reproductive anatomy and physiology, and then talk a little bit about natural family planning, and maybe a little bit about the research. And I am also very excited about what Mira is doing in regards to the quantitative levels of hormones in the urine, because I think that's a big leap in regards to natural family planning, women's health, the vital sign, and everything. But so that we're on the same page, I thought just a little bit of brief anatomy and physiology. Dr. Bouchard could jump in any time and correct me, but let's see how this works. First of all, this is just the cross-section of women's reproductive organs. The middle is the womb or the uterus, and before the uterus is the vagina, and then there's two tubes that go off. They're called the uterine tubes or fallopian tubes, and on each side of the woman's body there are ovaries, and the ovaries are where the eggs are kept. Now at intercourse, approximately 3 to 5 million sperm are released at intercourse. However, only about 100 to 50 get up into the uterus. And at that time, if it's near ovulation or when the egg is released, that egg actually has chemicals that will call the sperm to that egg. The fallopian tubes also help in the flow of the sperms to the egg. And when the egg is united with the sperm, that's the beginning of the new human life. Now, the vagina, you can see at the bottom of the uterus, is called the cervix, or the neck of the uterus. That cervix is closed during most of the time of the woman's cycle. It is only at the time when an egg starts ripening and producing estrogen, which is very important. That's one of the most important hormones that will stimulate various cells in that cervix there to produce mucus, watery mucus that has sugars and salts and things like that, that actually nourish those sperm and aid in the transport. But it's only at a certain time. The other times the cervix is tight and closed, the mucus is dry, and actually it prevents germs and getting into the uterus.
I'll just jump in here, Richard.
Yes, okay.
One of the comments that often comes from people using natural family planning is related to mucus and how accurate it is at identifying the fertile window. And it is accurate in some cases, but there are certain cases, and Richard and I wrote a paper a few years ago about how breastfeeding and the hormones related to the time of breastfeeding and postpartum can really impact mucus quality. And the reality is that only 1/3 of the time do the hormones actually get reflected in the changes in mucus. So that's a challenge, and similar things can happen in PCOS as well. So one of the challenges with using mucus, although it can be an accurate sign in regular cycles, and certain women can get pretty good at identifying it, there are challenging times when mucus is not reflective, and so the use of the fertility monitor can really help a lot of women who are struggling with identifying mucus. And then if we can get some quantitative results, say from the Mira monitor, that will help us even more identify, well, is the mucus reflected in the hormones or not? And sometimes there will be some cycles and some situations in a woman's life where the mucus is reflected by the hormones, and other times it's not. So home fertility monitoring really helps to see whether there is correlation or not with an individual woman's mucus produced at the cervix.
Thank you, Dr. Bouchard. I do it a little bit easier. I say that mucus is a fuzzy indicator of fertility, whereas the hormones are more accurate indicators.
Right.
But back to the cervix, there are two, as I mentioned, when the egg ripens, estrogen goes up, it stimulates the cells along the cervix here. And it's that time where sperm can live and go up and fertilize a human egg that is developing or been released. After that happens, and we'll talk a little bit more about that, progesterone is being released. That stimulates to dry up the mucus, and sperm can no longer go through. We do know that a woman by herself is only fertile one day. That's the day of ovulation. However, the fertile window is longer because sperm can live, the lifespan of sperm is 3 to 5 days, but only in good cervical mucus. There's been studies showing it's about a 6-day fertile window, and actually on average, there's only 3 days during the fertile window. As I mentioned, the female ovaries, those are on both sides of the body. A baby girl, before she's born, when she's actually in her mother's womb, there's about 1 million or so, 1 to 2 million undeveloped eggs in the baby's ovary. Once a baby is born, there's about 1 million. By the time she reaches puberty, she has about 500,000 eggs. So you can see how the eggs actually decrease as the woman goes on. A woman will only ovulate about 400 times during her reproductive life. Now, there's chemicals, hormones from the brain that will stimulate egg to develop, and this just shows an egg in what we call a follicle developing. So when those hormones stimulate, the eggs become larger, and estrogen levels go up. And this shows a ripe follicle ready to be ovulate, and then there's another hormone called luteinizing hormone actually stimulates the egg to be released. That LH hormone, or luteinizing hormone, changes these cells of the follicle, and then progesterone is being released by the follicle, what is called the corpus luteum. So progesterone goes up after ovulation. That progesterone release actually heats up a woman's body, and that's why basal body temperature works in regards to a sign of fertility. It increases a woman's body temperature about 1 degree Fahrenheit. So to look at the important hormones, I mentioned that there are hormones from the brain, from the anterior pituitary gland called LH and FSH, luteinizing hormone and follicle stimulating hormone. Both of these hormones are important for stimulating ovulation. This is showing the egg and the follicle being developed in a ripe follicle. Now, if you could actually take pictures of this, you could be very precise in regards to day of ovulation. Actually, serial ultrasound could be able to track that and become very precise, and that actually is the gold standard. But you can't do that at home, at least now. So one of the better signs of the beginning of fertility is when the egg ripens and estrogen goes up. And this is the blue, light blue showing estrogen. So fertility begins about here when estrogen arises. We know the peak of fertility is when the LH surges. And then about 12 to 36 hours, ovulation will take place. So this is a good indicator of the peak of fertility, the LH. After that, again, these cells change due to the luteinizing hormones, and then you have progesterone that goes up, which drives the mucus and it maintains. And so if you can measure the progesterone levels, actually confirm that ovulation has taken place. Now, this progesterone is very important for developing the lining of the uterus. Without higher level and maintaining progesterone, this lining becomes very thin, and so a new human life would not be able to implant. So that's important that all these hormones are in sync with one another. I actually think that this is such a beautiful mechanism, and there must be a higher intelligence that thought about this.
Can I just jump in there, Richard?
Sure.
Some people will notice that their mucus peak that they can sense is like a day before peak on, say, something like the Clear Blue monitor. And that's well shown in this diagram where you see the peak of estrogen coming just before LH.
Right
but
here.
This is kind of an average diagrammatic form of the menstrual cycle. And so there are lots of variations in where LH surges, where the estrogen peaks, and it might not always be the same, but this diagram can kind of explain a little bit about why sometimes you'll get the mucus peak the day before the LH surge. And the relationship between that and ovulation is, within a few days, and we need to be able to precisely identify that. The only way to really identify is the LH surge and the estrogen peak followed by ovulation within a day or two is with an ultrasound test, like Dr. Fehring was mentioning about the tracking of the follicle development. So at some point in the future, it would be very useful to have a Mira ultrasound study where you could look at the data to be able to say, what are the chances of ovulation and what is the timing of ovulation in relation to the LH surge and the quantitative estrogen you might be getting.
Yes, and studies have shown that mucus, the peak of mucus is about 3 days before and 3 days after the actual day of ovulation, where the peak of mucus can be revealed through a woman's body. And so it's a fuzzy indicator, and that's actually 6 days where that can fall into. Whereas it's a lot more precise when you have the LH surge, which is only about 3 days in regards to variability. So people want to know what is natural family planning? Well, it's giving the woman and a couple methods of monitoring and interpreting a woman's natural biological markers of fertility. And that helps them to determine the fertile and infertile times of a woman's menstrual cycle. And knowing this, information can be used to achieve or to avoid pregnancy. NFP, when we talk about natural family planning, we ask couples to abstain from intercourse and general activity during the fertile time if they're avoiding pregnancy, but also developing ways of expressing intimacy during that time. We also say not using any artificial means to interfere with fertility. Now, you also will hear about fertility awareness-based methods, and that is learning about when a woman is fertile or not, but then using what people call either safe intercourse, condoms, or withdrawal during the fertile time. I also call them targeting condom use. So you might hear about fertility awareness-based methods, which is more of the generic term right now. Actually, the term natural family planning came from a NIH, National Institutes of Health conference back in 1972. It did not come from the Catholic Church or religion or anything like that. So it's a very secular term. So how does NFP work? So as I mentioned, there is only a 6-day fertile window, actually on average a 3-day window. The day of ovulation when the egg is released, and then the 5 days before. And this just shows a woman's menstrual cycle with the first day of menses here, which actually is the end of the of a menstrual cycle, but women know that they begin the new cycle when they have their menses. And this just shows a 6-day fertile window with the day of ovulation. We have 2 periods or phases. The pre-ovulatory phase are also called the follicular phase, and then the post-ovulatory phase, infertile phase, which is also called the luteal phase. Now, if it was the same day every cycle, you would just be able to count where these days are, but human beings, women, have variations in their time of their fertile window. And this just shows some variation from a normal cycle of 28 days. This woman here then ovulated earlier, and then she had a longer cycle and ovulated late. She might have had some stress at this cycle or overexercise or things like that. If the variability is greater than 7 days in regards to this, or even on the length, we already know that there might be some problems. Now, the natural biological signs of fertility are calendar formulas, or sometimes people call them rhythm. I have 1910 there. Back in the 1940s, 50s, people said, well, you could use the 1910 method. That means that on day 10, you begin your fertility, and day 19, your fertility ends. So the fertility window falls in that time. So there's a lot of different calendars formulas. In fact, one of the newer methods from Georgetown is called the standard day method. It's from the days 8 to 19 where the fertile window fits. Also, changes in body temperature. As I mentioned before, when progesterone, after ovulation, progesterone levels go up, the resting body temperature of a woman elevates about 1 degree. So if a woman takes her temperature every morning, she'll be able to see that shift and have an indicator of when ovulation has taken place. We also mentioned the changes in the cervical mucus. Cervical mucus is important for fertility, but changes in female hormones are very exciting. Back in 1990, Dr. Gerasi, who was one of the developers of the birth control pill, wrote an article in Science magazine, and he called that jet age natural family planning. He said, in the future, we will have women be able to actually monitor their female hormones to determine when they're fertile or not for jet age natural family planning. Well, in the 80s and 90s, technology developed where women be able to measure LH surges. There's also monitors to qualitative measure female hormones. So, and now we're actually going into a leap in regards to having quantitative levels, which is very exciting. So the basic instructions for NFP is to achieve pregnancy, have intercourse during the fertile window. Actually, the 2 days before ovulation are the most fertile time. It's about 36% in a younger, early 20-age women about the day before. So that's a good time, those 2 days before ovulation. To avoid pregnancy, you don't have intercourse during the fertile window. There's a biological fertile window or what we call the estimated fertile window through utilizing indicators. And people had questions about how effective is natural family planning. Well, the World Health Organization has a flyer like this showing that natural family planning is way down below 24%. Well, that has changed. The CDC just recently has changed its levels of effectiveness for natural family planning. So this one right now is not accurate. It's actually kind of biased. And I'm going to show you a little bit. Now, people need to know that there are 2 terms and 2 types of effectiveness that you need to know. One is called perfect use. That means when it's used correctly by the woman and the couple. and follow it consistently and correctly. That means charting every day, monitoring every day. Or if you're even on the birth control pill, that means taking the birth control pill every day. However, human beings are not always perfect, so there's called typical use. And that's when you miss tests, you don't chart correctly. If you add those cycles where you don't do it correctly with the perfect use cycles, you get typical use, which is actually what you call average use in regards to effectiveness. So those are the two terms that you see are two type of numbers. This is just a listing of studies that we have done, or has been done by various people since 1981 in regards to methods of natural family planning. You can see that we're looking at percentages of survival. It's one way that you can look at. So 78% for the mucus method, and correct use is 97%. I'll talk a little bit more about this in regards to some specific studies, especially that we have conducted and Dr. Bouchard and I have conducted in regards to natural family planning effectiveness. Essentially, it is easier to do studies when women are in regular cycles and get good results. It's when you get into difficult cycles like postpartum, perimenopausal, where it gets a lot of variability, which becomes a little bit more difficult. So this is where I see methods of natural family planning fitting with other methods. Just by chance, random intercourse, we know that 85% of women will get pregnant within 12 months. Spermicide, about 29% will get pregnant within a month using spermicides. Withdrawal is about 27%. The ovulation or mucus method is about 19 to 25. Condom is about 15. The standard day method, that's the calendar base, is about 12. The symptothermal is from 2 to 11. So it's about 98 to 89% effective. The market model, especially market model 2, perfect use is from 0 to about 98%, and about 98% to 90 to 90% regards to effectiveness. And that's comparable. These two methods are very much comparable with the birth control pill, which gets about 8 unattended pregnancies per 100 women or 12 months of use. There was a study that was came out in October of 2018 by a group of researchers, Dr. Rachel Uricchio, Dr. Stanford, Dr. Polis, and it was published in the Green Journal, which is one of the top journals of obstetric and gynecology in the United States. And they showed that the two best methods were the symptothermal, the German symptothermal, and also the Marquette method in regard to avoiding pregnancy. That study also influenced the CDC to change their effectiveness rates of natural family planning. So, effectiveness of the market model achieving pregnancy during, or achieving pregnancy. Okay, we talked about avoiding pregnancy, but you can, because it's not a method of contraception, it's actually living with your fertility, you can use the same information to actually achieve pregnancy. 2 years ago, I attended a conference in Washington, D.C., where they had the natural family planning experts meet. And they had one of the experts talk about achieving pregnancy with natural family planning. And this expert from California, this physician from California, presented two things. First, he presented the study that Dr. Bouchard and I did in regards to achieving pregnancy, and then he gave ways to optimize fertility. I'm just going to briefly show that. So we do have a special protocol that utilizes a hormonal monitor, and we looked at that in comparison with mucus. We had 256 women. Their range of trying to get pregnant was from 0 to 131 days. And this is our final results. We looked at it over 24 cycles. So with the monitor, the fertility hormonal monitor, by 24 months, we had 100% in regards to over 24 months of use. The mucus, we didn't have enough power, but you could see at 12 months, about 72. And if you added the fuzzy indicator along with the more accurate, with the monitor measuring the hormones, you only had a 79. So we showed difference. So we do think that being able to be accurate with the hormones that you're going to be better chance of getting pregnancy. There's also been a couple other randomized studies with these hormonal monitors showing the same thing. 2 more slides, and then I'll let Dr. Bashar talk a little bit about the practice committee of the American Society of Reproductive Medicine, in collaboration with the Society for Reproductive Endocrinology and Fertility, released an article in 2017 in the journal Fertility Sterility, which is one of the top fertility journals. And they talked about ways of optimizing fertility, which I think is very important for women. First of all, fertility knowledge among women and young adults, men and women, is very low. And there's studies after studies. In fact, one of my recent PhD students did a study looking at fertility knowledge, developed a tool, and showed how people don't have a good knowledge of their fertility. Age, the best time of getting pregnant is in the early 20s. It's not waiting until your 30s. And actually, by the time you get into the 30s, your fertility has decreased by 50%. By age 35, fertility goes down a lot. We do know that the threshold of fertility is around age 42 or 43. Now, there's a few women who get pregnant after 44, 45, but it's very, very low type of pregnancy rate. So the best time to get pregnant is early 20s. It's also a good time to test your fertility at that time. Or if you have problems at that time, it's best to get it checked. Now, intercourse, most people, this article suggested that probably the best is to have intercourse every day. I think that would be difficult, so it recommends every other day. That is for the best sperm quality and quantity. However, that's difficult for women and couples to keep on having intercourse every other day or even daily. So we know that you aren't going to get pregnant unless you have intercourse during that fertile window. So we advocate focusing intercourse during the fertile window, and especially the 2 days before. It'd be a good idea to have intercourse outside of the fertile window to keep the sperm levels up. Normal weight is very important. If you're overweight, underweight, it's going to be more difficult getting pregnant. And also lifestyle has a lot to do with regular exercise, good diet like the Mediterranean. No marijuana use, that's not good for the man or the woman. Too much coffee, too much alcohol probably is not a good idea. So we know that the menstrual cycle, and this is my last slide, menstrual cycle is a vital sign of the woman's health, is very important. So actually ovulation is the best sign that a woman is very healthy. It's almost like an early little bird in the mind in regards to picking up problems that might be happening. We know that the norm of the length of the menstrual cycles is 21 to 36 days. You're below or above that, there's indication right there, there's probably some problems. Even if you're near those numbers of 21 to 36 days, there might be some problems. We also know the patterns of the pre-ovulatory and post-ovulatory phase. If it's too short, too long, we know there might be some difficulties. However, with this leap in technology, now that we have quantitative hormones, it's going to be more and more exciting to be able to see more patterns, the patterns of LH surges. If you have too many LH surges, that might be an indication of polycystic ovarian syndrome. Could be other problems happening. So I look at this new technology of helping the assessment and diagnostics, especially having a home device to be able to look at that, and also make better and easier protocols for using natural family planning for both avoiding and achieving pregnancy. So that's my last slide. I think. Thank
you so much, Dr. Fehring.
All right, go on. Mm-hmm.
Yeah, I think this is really helpful, and you cover a lot of topic here. We talk about the what hormones are important and why they're important, what is natural family planning. We also talked about how effective the method is, and we can even use that for trying to get pregnant, right? So I think this is great. So we actually got a lot of interesting questions while you're talking about this. So one thing is I think a lot of people wants to know that, now Mira can track 2 hormones instead of 1. So by tracking this additional estrogen hormone, just from a doctor's perspective, where do you think are some potential benefits? We obviously know, they can track for fertile window or the non-fertile window, but is there anything else, the patient or the user needs to pay attention to say, okay, maybe my estrogen is higher or lower, that can potentially indicate something?
I'll just jump in here. I was kind of watching a few of the questions that pop up. The first thing that we need to know about the Mira monitor is how is it reflective of what we already know. So that's why we have to do a comparison with the Clearblue monitor, and we can't just automatically jump to Mira with the Marquette algorithm, because we need to know how the monitor behaves. So a few questions that came up on the Q&A was related to having an LH surge right after the period, and then having a later LH surge. And one of the Mira folks, I think Kristen, answered that question about the fact that they have to kind of look at the monitor and just evaluate which one is correct. The reality is, just like with the Clearblue monitor when Dr. Fehring was first studying it, we have to look at a lot of people's cycles to see, well, what is the behavior of the monitor? What kind of variability is there in the estrogen results and the LH results, to give an accurate idea of troubleshooting, right? Because every monitor is going to have, some days where it's, maybe the test stick itself is a problem, or what are the numbers in an individual cycle and how to interpret that. The only way we'll really be able to answer those questions is after many users over a while have used the monitor, so we can start troubleshooting and identifying those things. But the first step really is comparing Clearblue to Mira, from comparing a known entity to an unknown entity, so we can start saying what is the behavior of Mira compared to what we're getting on the Clearblue monitor, which we have over 20 years of experience with, right? So that's a first step. So lots of people are really excited about seeing what can be used, what the Mira monitor can be used for. And I think we just have to, keep comparing and seeing, taking it one step at a time to know how we can use the Mira monitor best with quantitative results. Sylvia, your comment was, what clinical situations besides avoiding or achieving pregnancy could the Mira quantitative results be helped by? And that I think is one of the biggest advantages of quantitative results, is being able to say, in somebody with PCOS cycles, what is the behavior of estrogen in a lead up to a potential ovulation or no ovulation in a given PCOS cycle with no ovulation that's happening. Another example of where the quantitative data would be useful is in the postpartum period, where women using the Clearblue monitor are getting days and days of highs without getting a peak. And we don't really know with Clearblue when estrogen goes back down, whereas a quantitative monitor would allow us to know when it's going down again, rather than having to reset and wait for another low on the Clearblue monitor. Mm-hmm. The same thing could happen in the perimenopause, where you might see for months and months very low levels of estrogen that would give you more details about what's happening in the perimenopause. So the behavior of the increase and the decrease in estrogen will be very helpful in analyzing cycle problems, and also assisting people who struggle with either achieving or avoiding pregnancy by knowing when estrogen is going up and down. And then also seeing, well, what is the absolute peak of the LH surge? Can we say anything about people who have smaller absolute values in their LH surges versus just a number past a threshold, right? So Clearblue gives you a peak after it passes a certain threshold, but maybe if you could see that a given woman always had these low LH and results, maybe she wasn't getting peak on the Clearblue monitor because her baseline is lower LH than average, right? So these are some examples of things where quantitative data is going to be helpful for us.
Sure, sure. Very good. Oh, go ahead, Dr. Fehring.
Yeah, I would just like to add to that. You know, after we do our studies, we'll be able to start establishing normative levels of these hormones in regards to what we call 95% confidence intervals, where that we could say, yes, you're in the normal range of these hormones or outside of the range. So that will be helpful. And again, as Dr. Bouchard mentioned, that we'll be able to see patterns. Now, if you, even on the slide or the that you have right now on the screen, you can see where the estrogen, estradiol, is a peak right before ovulation. So if you see that pattern, you'll know that you probably have a good menstrual cycle going on here because of the stimulation of the estrogen going on. So that's what I think is going to be very exciting. We also know that in urine, when you have the progesterone along with the Mera, that's going to be exciting too, because we know that the serum is not accurate in regards to determining a woman's progesterone level because of the pulsatile nature of that. However, the urine progesterone levels will even that out and give you a little bit more accurate records of where the progesterone is, whether it's a healthy menstrual cycle or not. In regards to the, Dr. Bouchard talked about the postpartum protocol. When we developed our protocol, we had Dr. Michael Zinnemann, who was a reproductive endocrinologist. He was at Georgetown, and then when he came to Marquette, he was at Loyola University School of Medicine. And he was in the original studies with the clear blue, and he was speculating in regards to some kind of ways of monitoring the postpartum, what we call cycle 0, transition to fertility. And he was suggesting that you would maybe just test once or twice a week until the estrogen level starts rising. Well, with the clear blue, that doesn't work very well because you get qualitative levels. However, getting quantitative levels, there might be some kind of threshold where we say, well, now you have to start checking your estrogen every day, and then it might go again and you could stop again. So to me, it's going to be exciting in regards to developing various protocols with much more information.
And another thing with regards to concentration that people often ask is related to absolute values. And the kidneys are a concentrator, right? So as Richard mentioned, serum will often have surges in different hormones. So urine is a pretty good medium to test because the kidneys have concentrated something over a certain amount of time. So this highlights the fact that most monitors, including Mira, you want to have concentrated urine in general. And if you're not doing first morning urine, because Mira will allow you to test at other times in the day, you want to allow concentration to happen to get the best test results. So that could be, for example, limiting water intake, waiting 4 hours between a void before you test, for example. So whether it's kind of this new combo stick with estrogen and LH, or later with the progesterone, you want to allow the kidneys to concentrate the results so you get the best data possible on the monitor. Otherwise, it's not going to be as accurate.
Totally agree. So thanks both. So just to add on top of that, regarding the question about correlation between urine and the blood, so there's actually a lot of papers done about that as well. So for LH, estrogen, progesterone, there's really strong correlation. I don't have exactly data in front of me, but that correlation is about, I think it's between like 80 to 85 or something percentage around that level. So because the urine is the metabolized product, the hormone urine is a metabolized product from your blood. So you will never get exactly same number, but the trend and the pattern you're seeing should be very similar.
Now, I have another thought. I was reading a paper yesterday that you can also determine the fertile window through a ratio of estrogen and progesterone. So we're going to be having, when the monitor has both of those, and they determined through the study that you could determine by a 10-day estimation of the fertile window. Right now, the natural family planning methods is, the fertile window, estimated fertile window average is about 12, 13 days. So we can shorten that time that people have to avoid intercourse, maybe even with a simple type of ratio type of measure that could be built into a system.
Yeah, Dr. Maria Myers also commented in the Q&A that same thing, right? So ratios, I think, are definitely on the agenda to study, to see what the issue is as far as the fertile window, the when infertility starts after ovulation, and if we have progesterone as well, ratios with progesterone will be helpful too. So the quantitative data is what will allow us to start doing ratios, which we haven't really been able to do from home.
Another thing I like to point out is that during a home urine testing compared to going to clinics and getting your blood tested, and that gets very, very expensive. This could be a much more powerful way in regards to an inexpensive way of getting good data for diagnostics.
Yes, that's definitely very true. So another few questions we're seeing in the Q&A is about the quantitative hormone. So obviously everyone's different and the variability is very big. So quantitative hormone will give you much more insights about your cycle and give you a personalized situation, and doctor will have more insights to help you as well. But on the other side, because of personal variation or so on, sometimes there could be some confusion for the consumers, or they may not have the or that might need a little bit of medical knowledge or need some understanding about themselves to correctly understand what's going on. So from a doctor's perspective, do you guys have any advice to our users or to your patients when they see their real data?
Yes, the market model of natural family planning, all of our teachers are health professionals. And so couples work with health professionals to help interpret cycles and what's going on, and also to find out whether they're, to be able to detect early that problems might be happening. And if the health professional that they're working with cannot help them, they know where or who to refer to. So I like a system where a system like that you have, that couples will be working with a health professionals like we do with the market model. I might be biased, but I think that's a good way. It gives them credibility also.
Yeah, and I agree that being able to connect with the health professional, doing it with virtual technology, being able to email and connect to an NFP provider is really kind of key to moving forward. The other thing too is, as women start knowing their cycle, they can start to have a sense of when things are going to happen, right? There was a question about somebody getting a high LH on the Mera monitor on day 8, and then there was a later high LH in their cycle, right? So these are the types of details that we have to work out with the Mera monitor, so you can be able to say, if you're getting a high LH on day 5, 6, 7, that's not something that you would expect when you're thinking about a regular cycle. And in that context, the more knowledge you have about your cycle, the more you're able to interpret the data. And if you have more hormones, that will also help you interpret the data if ratios become something that we could use as well.
That early spike might be an indication of, well, it could be perimenopause. As a woman goes through perimenopause, actually starts developing those eggs in the previous cycle. So you'll have long cycles and then also a very short one. So that could be an indication of the variability in perimenopause, but it also could be an indication of PCOS in regards to having spikes. So I think there was a question in regards to, can you use this with PCOS? My first comment for people saying using NFP or tracking like this, first of all, is you need to manage your PCOS, and if it's managed well, then you're going to have good cycles, be able to monitor it. However, monitoring your hormones and your cycle will actually tell you whether your management is working well or not. So both ways is also going to help you for diagnostics.
Sylvia, can I just ask whether you have any comments about user feedback in terms of results that are unexpected, LH results, even in your alpha trials of the combo test stick, how you handle the unusual results you might get.
Yeah, sure. So we, what Mira is really trying to do is to bridge the medical science and the consumer. So we got actually a lot of questions, and people are like, okay, how come my hormone is not perfectly as the the curve we're showing on the screen, and maybe I got a peak earlier, maybe I got a peak later, and this is not what I expected. I thought I ovulated earlier, later, all these kind of different questions. So we're basically doing two things. So the first thing is we're constantly improving our algorithm. So our algorithm is pretty dynamic right now, so it will never determine an ovulation and in future the fertile window based on a fixed hormone threshold. So it will once at the beginning of your first cycle using that, it will start with something relatively to the population average, but it will gradually learn. From a second cycle, it will start to really decide what's happening based on what happened in your first cycle, and you will say, maybe your threshold is earlier or later or whatsoever. And some people do have multiple surges, or we don't even call them surges, just fluctuation in the baseline of the hormone, but those fluctuation looks, stronger, or the magnitude is higher than a normal, very low, small fluctuation. And in that case, we usually, we'll give you all this information. So if you're trying to, get pregnant without the further medical advice, we usually recommend you to try to have sex during all these days in case that is the ovulation, because you never know what's going to happen after that peak. Do you still have another peak? And the second thing is like the algorithm, gradually learn the cycle, and we'll start to decide, okay, so this might be, we recommend might be your baseline, or baseline could be higher, could be lower, whatsoever. So that's one side of the thing we're doing. And the second side of the thing we're doing is like we're really trying to, provide some analysis for our user. Mira doesn't really provide the medical advice. We're more like a testing device, but we will provide you information such as how does this compare with what we're seeing, our average user? How does this compare with your previous cycle? Maybe this might be your ovulation, might be something, a pattern might be very obvious. So, this is something you might want to pay attention to. And if we see things that's really irregular, and we will recommend, the person to go to see a doctor. We actually had a case like that. There's a user reaching out to us saying, I didn't have my period, and I test every other day. I never captured the peak. So, what's wrong with the product? And we said, okay, maybe you didn't ovulate at all. So you want to go to, bring the data to your doctor to see what they have to say. And she went there, and then she said the doctor was pretty impressed and saying, maybe she has PCOS or something, but obviously she didn't really ovulate in the past 3 months. Without data like this, it's just, hard for the doctor to really diagnose what happened in the past. So, in basically in general, it's a combination. There's definitely challenge, from a product and from an industry perspective. I see there's definitely challenge to bring the real data to the consumer who doesn't have the professional medical background. But on the other side, I'm pretty surprised to see a lot of women, they appreciate this. We keep telling our users, Mira is really at least we want to help you to know better about yourself. So knowing better about yourself, know your hormone, know your pattern, pay attention, be more mindful, or, if you want to, observe mucus or even test your body temperature, all these are good behavior. You will start to know better about yourself. And in that process, since we'll not be that perfect, but we're here to help, and you can seek for doctor's help too. And gradually we will, we really try to have you to have better control of your body, your fertility. So, it's going to be a process to really get there, right? Because everyone's different, and everyone has certain level to, about how to accept the data they're seeing, how to interpret it, but we're working on that.
Sylvia, do you have any sense of what you're seeing in morning versus afternoon tests? Any comments about that?
So I have to go back to check the data, but we do see a lot of ovulation happen in the afternoon. Or I wouldn't say ovulation, I would say LH surge. That's more accurate. Yeah, LH surge happen in the afternoon. So I think that could be something like people used to complain like, oh, I missed my ovulation or LH surge. I'm testing with the OPK. That could be why. And we also think that some LH surges happen so quickly. We got a lot of user questions saying, okay, I got really low, minimal in the morning, but I got a really high and in the afternoon, like 60 something, and I tested at night and it's just back to 0. So what happened with me? So things happen really quickly. So that's a challenge for LH testing. You really got to capture that thing, that whole thing could be happening in 12 hours and just back to none. If you miss that 12 hours, you just don't see anything. Yeah.
Some people need to do twice-a-day testing, morning and afternoon. I'd like to comment on some of the comments that you just made. When I tell women in regards to when they have one cycle is kind of screwed up in that, I said in order to get a good picture, you need to have 3 to 6 cycles, be able to see patterns or what are happening. We also know that there's a lot of different patterns, even with the LH surge. There is where you go up and then there's plateaus. There could be also double peaks and things like that. There's some speculation, however, those plateaus and double peaks are of cycles that are not fertile, but that needs more research.
Yeah, a few thoughts with regards to more than morning testing. I would say that's more relevant to LH than estrogen. I don't see a huge value in twice daily testing for estrogen, but around the time of ovulation, especially in special cases, you might consider twice daily testing, but not as a usual. Morning testing, I think, is still the most valid.
Especially if the person's missing the LH surge.
Yeah, exactly. That's more of a special case, I would say. There was another good question from Michaela Dalton, who's commenting on complexity in NFP if we have quantitative results as well as, say, ratios of estrogen to LH. That's very true. And a lot of people, including the clear blue people, argue for simplicity like low, high, peak for the sake of allowing interpretation for the end user to be simpler. That is also true. So
Thomas also their persona, which is red light, green light.
Exactly, yeah. And so what Mira has done is gives you quantitative data, but they also have this algorithm where you get the scale from 0 to 10, which tries to simplify that interpretation. If you use the Marquette method, you're also simplifying it with the help of the algorithm, right? So all this to say that there is complexity that's added with having more data, more number points to look at, and that is more complex for the end user. And it just goes to show you that in the research, there also has to be definite user-related satisfaction that you can evaluate to say, is this complexity problematic? How do we deal with the complexity of the data for the end user to be able to still interpret it with the help of an algorithm or a method like the Marquette method overlaid over the Mira data?
Sounds very good. So I think we have a lot of interesting questions and we had a great discussion, but we're kind of running out of time. So maybe one last question, maybe two doctors, you can give our audience some advice or suggestions. I know it's a tough time for everyone. Many people are still sheltering at home and they cannot go to doctors, they cannot go to fertility treatment. So either they're trying to avoid pregnancy or trying to get pregnant, or even with some PCOS hormone conditions. What are some suggestions you could give them to go through this tough time?
My advice would make sure that you get outside in the sun and walk and get some good exercise and get cooped up, because that's not good. That's not good for your health or your fertility. Secondly, we have a lot of people, you can Google Marquette model or Marquette whole mission. There's a lot of people that teach online. In fact, one of the doctors that asked the question, Dr. Maria Myers, is one of the persons that teach online. So that could be a source for people to get to information.
My final comments, again, with regards to the the quarantine situation is just continuing to have good family time, good couple time as a couple, and maybe there will be lots of babies born out of this isolation time, which should be totally fine. And then there'll be a lot more questions about the postpartum period that we'll have to answer as well 9 months from now. But the other thing I would say too is you could probably expect data from our trial, comparison trial, Clear Blue to Mira, this fall. And really the only way we'll be able to give you more detailed answers to questions will be after we see the two monitors behaving next to each other. So we're looking forward to that. I know everybody's really excited about seeing what the potential is for the Mira monitor, and I am too. And it's really a matter of waiting and seeing, right? We don't have all the answers right now. We do have to see what happens over time, over a lot of users kind of seeing what the monitor shows, comparing it to something that we already know, like the Clear Blue monitor. And then we'll have more things that we can share with you in the fall, so that we can get more detailed kind of understanding of the menstrual cycle from home.
Sounds great. So yeah, so from my perspective, I saw some questions about when Mira will release the next product. So the estrogen product is under pre-order right now, so you can actually get it from our website. We are expecting to launch that in 2 to 3 months. Depends on how the pandemic situation gonna go, but 2 to 3 months is a pretty reasonable time frame. We don't expect too much delay from that. And then the next step will be the progesterone test, which are expected later this year or early next year. Again, depends on how the pandemic and the overall situation gonna go. So I just want to say thank you so much to doctors to join us today. I think you guys shared wonderful, very helpful, very supportive insights about the the hormone, about our physiology, and also about natural family planning with us. And for all our participants, I really, really appreciate your time. I hope this could be helpful to you. And also, I hope the, during the quarantine time, Mira could be something that help you to learn more about your body.
Thank you for the opportunity, and be safe, be healthy, and be at peace.